In terms of getting an idea about which drugs are commonly used in cardiac arrest, this study from the Resuscitation Outcome Consortium was quite informative, and it was a review of 16,000 out-of-hospital cardiac arrest cases from 74 EMS agencies, and it gives you an idea of the frequency with which various drugs are used in cardiac arrest, with 80% or more than 70% receiving adrenaline and atropine, bicarbonate being used in about 15%, and as we've just heard, amiodarone and lidocaine being used in smaller proportions. Of course, if we look back over the history of CPR, and on the left-hand side we've got some of the seminal works from Peter Safar, with, I guess, the first universal treatment algorithm presented there on how to deliver advanced life support. And within that algorithm, several drugs recommended: epinephrine, bicarbonate, calcium, plasma, dextran, saline, and noradrenaline. And then over on the right-hand side, from the mid-80s, the American Heart Association guidelines, including the use of epinephrine, bicarbonate, and other pharmacological therapies. So, given that we've already had talks focusing on the use of vasopressors or epinephrine and antiarrhythmics, I thought I'd take a step back and look at the concept of introducing drugs into an EMS system. And I think this is beautifully demonstrated by the excellent work from Ian Steele and the OPALS research group. Now, this was a multi-phase study that was conducted some time ago, but it looked at upgrading or improving the delivery of emergency services outside of a hospital. So they started off with their system having basic life support units, and then they trained up units so that they could deliver advanced life support, and alongside that in a whole programme of care that wasn't just limited to cardiac arrest, but covered the whole spectrum of out-of-hospital care. That they were able to pick out and to study the incremental value of introducing advanced life support interventions. And of course, it was a composite intervention in that it wasn't solely related to the administration of drugs, although the majority of patients during the advanced life support phase did indeed receive drugs, but it also included advanced airway management. And so any interpretation of this needs to be taken in the context of the information that Joey Nolan presented first thing this morning. This is the survival rates over time, and you can see that during the focus on the defibrillation and basic life support phase, the optimising that phase, moving into the advanced life support phase where drugs were introduced, that there was no increase in overall survival. And indeed, when you look at the survival outcomes, some parallels between the data that Mike Danino presented, bearing in mind most of these patients received epinephrine, that there was an increase in return of spontaneous circulation, an increase in admission to hospital, but no difference in survival to hospital discharge, and no difference in neurological function. And numbers quite big, with 1,400 patients in the pre-arm and nearly 4,500 in the post-arm. And this slide I'll come to again later on in talks, but I think it helps really put drugs into the context of the overall chain of survival. And so if you look at the impact of the early part of optimisation, early access to the bystander, increasing the odds of survival fourfold, early bystander CPR 3.7-fold, and early prompt defibrillation with a 3.4-fold increase, but no overall difference in the introduction of advanced life support. And of course, this isn't the only study, observational study, to have evaluated the use or the introduction of drugs. And again, these are data from the States that have been recently published based on the Medicare billing for patients that sustain an out-of-hospital cardiac arrest. They were able to look at the difference in survival between patients that were treated only with the basic life support group, but all compared to the group with the advanced life support paramedics attending the patient. And a significant difference both in survival up to 90 days, but beyond, favouring people where the focus was on basic life support. So the first and indeed probably the only high quality large randomised controlled trials to look at this specific question of whether drugs are of value is the work from Teresa Wallace-Gevengen, Lars Wick and the Norwegian group, which was the intravenous drug administration during out of hospital cardiac arrest, and they randomised 851 patients to receive intravascular access followed by the administration of drugs versus no intravascular access and no drugs. And this is the overall summary of findings. There was no significant dip, or there was an early signal for return of spontaneous circulation, admission to intensive care, but no difference in survival to discharge. And if you broke that down by rhythms, then patients with an initially shockable rhythm, no survival advantage across the spectrum of outcomes. And for those with PEA and asystole, early improvement in ROSC and admission, but no overall difference in survival to hospital discharge. So let's have a look. So that's, I guess, the data looking at drugs per se rather than focusing in on specific agents. But if we were to think about specific agents, over on the shockable side of the algorithm, we've got antiarrhythmics, vasopressors and reperfusion. And on the non-shockable side, we've got vasopressors and a focus on reversible causes. And then if we obtain a return of spontaneous circulation, a focus on stabilisation and neuroprotection. Now, I'm not going to repeat the excellent talks from the previous speakers, other than to note the conclusion from Dr. Tagami. Recent systematic reviews of meta-analyses suggest that amiodarone, lidocaine and nickel-fence therapies equally improve survival to hospital admission compared to placebo, and all of these improve long-term outcomes. And then Mike Domino's excellent summary and synthesis of the place of epinephrine, again, still leaving some uncertainty, no compelling trials showing us that epinephrine improves long-term survival. So moving from those two primary agents to consider vasopressin. So vasopressin is a potent vasoconstrictor, and mechanistically it acts in a similar way to epinephrine by increasing aortic diastolic pressure, and therefore increasing coronary perfusion pressure potentially increases the chance of return of spontaneous circulation. But in a large number of randomised controlled trials, which are summarised here in this meta-analysis, either adding vasopressin alongside epinephrine or giving it in place of epinephrine leads to no overall improvement in survival. Moving over to think on the right-hand side of the universal treatment algorithm, atropine used to be a drug that was widely used in the treatment of cardiac arrest, and indeed in the Glover data, you'll recall that 70% of patients were still receiving atropine as part of their out-of-hospital cardiac arrest treatment. And the concept behind atropine is that it blocks vagal nerve activity and can increase sinus node automaticity and AV conduction. But interestingly, despite the fact that the drug's still being used fairly frequently, the evidence underpinning the use of adrenaline is really quite sparse and is limited to studies such as this study from the late 1970s, which was an observational study, 3 patients out of a total of 8 patients surviving to go home from hospital. The only randomised controlled trial, and I've called it a pseudo-randomised controlled trial because it was based on the day of the week as opposed to true randomisation, involved a small number of patients. It involved just 21 patients, and as you can see on the right-hand side of the slide, there was no overall difference in survival outcomes, with indeed very poor survival for any of these patients. And indeed, since 2010, ILCOR has recommended against the routine use of atropine, given the paucity of evidence to inform it. Moving on to consider bicarbonate, a large number of observationals have considered bicarbonate. Again, the concept behind bicarbonate is that you develop a metabolic acidosis in cardiac arrest, and that it provides some buffering and therefore may improve the response to epinephrine and other drugs. But again, if you look at the trial data for this, there have been 2 trials. This trial looked at a specific formulation, Tribonate, and found no overall difference in survival between patients receiving bicarbonate versus placebo. And in this study, which again was a large study, this was focused on patients with VF out of hospital cardiac arrest.